discussion today will be on COVID reflections and the way forward. Before I introduce both guests, I wanted to give some words on today's format. I'm Punita Kumar Sinha, Chairperson of InCred AMC, and I will spend 30 to 40 minutes discussing with our two panelists about COVID and their thoughts. After that, our healthcare pharma fund manager, Aditya Khemka, is going to ask a few questions and then moderate the Q&A from the audience. This webinar will be recorded. So we have with us two very, very distinguished guests to shed some light on this very important and critical topic, Dr. Ivers and Dr. Karan. A brief introduction of both our guests. Dr. Ivers is Interim Chief, Division of Infectious Diseases, Executive Director, Center for Global Health at Mass General Hospital, and a professor at Harvard Medical School. Dr. Ivers is also involved in global policy and advocacy work to improve health equity. She has served as an advisor to the WHO and the Haitian Ministry of Health, and is a delegate to the Global Task Force for Cholera Control at WHO. Additionally, Dr. Ivers has worked on healthcare delivery in India, Southeast Asia, and Africa. Dr. Ivers has won many awards, including the 2019 Harvard School of Public Health Award for Leadership in Practice of Public Health. Our second very distinguished guest is Dr. Karan. He's the chairman and consultant, critical care medicine at Manipal Hospitals. He's an expert in the management of all types of critically ill patients needing ICU care, including mechanical ventilation in uses of devices like EMCO. He has authored many chapters in national and international textbooks pertaining to critical care medicine. Also, he has numerous research publications in both national and international journals. Dr. Karan is trained both in India and overseas. He's a senior national faculty in various regional, national, and international conferences. Dr. Karan has been in the trenches dealing with critically ill COVID patients and is also on a COVID task force in India. A very good morning to you, Dr. Ivers. You're joining us very early in the morning from Boston. Thank you very much. And good evening to you, Dr. Karan. Thank you both for joining us today. My first question is to you, Dr. Ivers. As you know, India has gone through a very devastating second wave. How do you place it in a global context and compare it to US and UK?
Yeah, first, I thank you very much for inviting me to join you. Yeah, I mean, it's been really heart-wrenching for me here, many thousands of miles away, to see what my colleagues are going through on the front lines of providing care. And we have many Indian and Indian American colleagues here in Boston who've been dealing with family and friends. So I really wanted to express my empathy towards the situation. You know, when you look at the number of cases per million that you've been having in recent weeks in India, it's clearly way up there in the top of the global scale in terms of numbers. We are seeing similar per population numbers in countries like Brazil, in Colombia, in Latin America, but obviously with such a large population, India is contributing a large number of cases when we look at the global map. And then unfortunately, of course, reaching this terrible milestone of having 300,000 recorded deaths. So I think what we've seen in other countries is surges like this, but obviously with such a large population, just the devastation and the human toll really so much more profound in your country.
No, UK was also hit very hard by the B117 variant. Do you think that this B617 variant is more vicious?
You know, it seems to, when I think about outbreaks in any scenario, you think about the virus itself in this scenario, and then the social context in which the pathogen, the virus, is finding itself. And it's hard to distinguish sometimes exactly how much each piece is contributing. It certainly seems as though the 617 variant is very infectious and maybe twice as infectious, maybe twice as transmissible. And I think you also have to look at where that virus finds itself. So for example, we are having some of both the variant 617, the 117 in the US, but because of our social context and our vaccine context now, we're not seeing the same level of impact of the same variant. So I think it is important to think about the variants. And I think we'll probably talk more about that during this time, especially because we worry about future variants and the vaccines not working for them, or tests perhaps being more challenging for certain variants. But I also think it's important to think of the variant and all of the components of public health that we know still work for the variants, whatever the variants are. So does that make sense?
Mm-hmm. Yeah, and I think we'll come back to the discussion of variants with you later, but I wanted to turn to Dr. Karan. Dr. Karan, how are you seeing this variant versus the one we saw in the first wave in India? And this variant seems to be affecting younger men in urban areas more than women. Do you have any thing you can share with us on that?
Thank you for having me in. So I think part of that question has already been answered by Professor Ivers. So I think whenever we talk about a virus and its infectivity, or any microorganism and its infectivity, the context would be the pathogen, the host, and the social factors. So certainly the mutation has occurred, and there is reasonable data to say that this is probably twice as infective as the UK variant and 4 times as infective as the Virgin strain which started off the pandemic. I think that's one factor. The second factor is, of course, it is definitely affecting the younger population, as we have seen. If you look at the data from the first wave, 20 to 25% of, or in some states and cities, it was about 30% of the patients were under the age of 40. But the data from the ICMR and from my own state in Karnataka today, the young population of under 45 is around nearing 40% in the second wave. So certainly, as you have rightly put it, there are younger people who are getting infected this time, and it is cutting across all economic strata of society. I think that's another important sort of factor which is playing a role in this wave, if I may say. So I think both these factors, the greater virulence and the fact that we are seeing it infecting the younger population, is the big stark difference which is coming across in this second wave. And also, as you have seen in the media, there are more younger children who are getting infected, and that is what is making us predict that the third wave is likely to hit the younger population. Now, if you may ask what is the reason for this? I think a couple of social factors may also be playing a role. One is, of course, the vaccination pattern. We have vaccinated the frontline healthcare workers and the elderly people, or the above 45, were targeted in the first wave of vaccination. And that has let the younger generation, who are actually the people who step out of the house and are in the livelihood activity, to actually get the infection and probably bring it home, but they are more susceptible and vulnerable because of the fact that they have not been vaccinated. So they are the unvaccinated population who are more directly exposed to the virus because of the activities or the livelihood activities and the fact that they step out of house. And of course, I should admit that there is a certain amount of carelessness which has also crept in the way people or society behaved in the last few months.
No, very valid point. But do you think that this variant has developed in a way that is also getting past the Indian immune systems, and then will it also affect the globally vaccinated, or the other countries who also have perhaps this variant emerge? But do you think this is going to kind of create a global problem?
Okay, so I think the data for that, to be categorically saying that this particular variant is causing more trouble, is still a little sketchy. We probably need more data. Some early signs do suggest that some of the vaccines may not be as efficacious, but there is definitely it is efficient. It's not that they are not. And we know that the mRNA-based vaccines still have reasonably good efficacy for this vaccine. But I think the data is still coming out. I'm subject to correction by Professor Ivers if there's anything. But as far as we know, there could be some early suggestion that the efficiency of some of the vaccines may be a little shade lesser. But having said that, I think this is not an answer, or this is not a reason for not getting vaccinated. I think more and more people get vaccinated, you will find that the cumulative efficiency of the vaccine continues to increase. And as we learn more about the vaccine, as we have seen the spacing of the 2 doses, we have increased. So as our experience with the vaccine and the disease gets better, we will probably have more data on that. But on the whole, I think vaccines are efficient, maybe a shade lesser, but they are definitely efficient. And I think the drive to continue aggressively vaccinating people needs to be continued.
Yeah, and I think before we go into vaccinations, which is a topic by itself, which we'll do later, just staying on the point of the variants, Dr. Ivers, what new variants do you see emerging, and what countries do you think, and places and geographies do you think it would emerge from, and where would the next hotspot potentially be that we should be worried about?
Yeah, I mean, I think trying to predict what variants will emerge is a big activity at the moment. I don't know that I can predict what's going to emerge, but I do think that when you look at the B617 variant and see that it had a couple of mutations that had been present in other mutations and now came together, one has to be very aggressive, let's say, in doing the surveillance that's required to identify variants, because obviously we're having mutations of the virus all the time, and sometimes those mutations have absolutely no impact on the clinical scenario for the virus. And so part of the difficulty to even answer your question is that as the virus is mutating, we don't really know yet exactly which mutations are going to give it an advantage in humans. And so it's just perniciously continuing to replicate, and any advantage that it gets, it will proceed along that line. So I think in terms of where the mutations will emerge, I think they're going to continue to emerge wherever the virus is replicating without being stopped. So the mutations, I think, will continue to emerge in any of the countries or geographies or communities, even within countries where there are unvaccinated people who are coming together and transmitting from one to the other. So this is why, as Dr. Karanth is saying, vaccination is really the way to prevent mutations. The more people who are vaccinated, the less chance the virus is transmitted, and therefore the less chance that it has to replicate. So it's a little hard to exactly predict, but if you look at other countries around the world, other continents, I think, you know, the continent of Africa is also overall far fewer percentage of the population vaccinated than in some countries in US, UK, and Europe. So I think we've heard Africa CDC leaders see what's happening in India and say, this is a wake-up call for the continent, and we have to double down on our activities, our public health activities, for concern and for fear of emergence of further surges there. We saw a variant P1 that was coming out of large surge of cases in Brazil, very infectious, and seemed to have some reduced impact from the vaccine. So I think anywhere we're seeing big surges, we're going to see new variants emerge.
So the solution...
just to add to what Professor Viver said, I think we, as mankind, one thing we need to understand is mutations are a natural process of evolution for the viruses. So we cannot stop that. I think the only protection we can offer ourselves is by boosting our immunity, which is by either a vaccine or by actually better herd immunity, which is going to be a combination of aggressive vaccination and, of course, infection of the population. So I think we need to understand that, you know, to answer the question that, you know, where it will come, it's unpredictable, as Professor Ivers mentioned. It can happen anywhere. It could again happen in a situation where people have been vaccinated, and you might find that the vaccine is ineffective. We hope it doesn't happen, but I think the more and more you vaccinate, the less and less it will happen. And the transmissibility of the virus is the one which determines the mutation.
So, I mean, since we're talking so much about vaccination, maybe I'll jump to that section right now. Now, in the US itself, Dr. Ivers, there have been some states which are about 60% vaccinated, and some are only 30% vaccinated. And so there is no consistency even in US, but there people have let their guard down as well. And people are now not required to wear masks in the areas where there have been vaccinations. But hearing from you all, this variant can get past various even the vaccinated people. So why are we letting our guard down and letting people take off their masks even if they're vaccinated?
Well, I think the US, has had a very complicated and not always very good at all response to the pandemic. I mean, we are up there in the world as the highest number of deaths. And, I can't say there's been too much. I mean, there have been pockets of great success and great science, but on a public health level, not exactly the model. However, one of the things that the US has been successful at is kind of aggressively trying to vaccinate our way out of the crisis. Now, that has had impact on other parts of the world, by the way, which we can come back to. But I think to answer your question, what the public health guidance now in the United States is that vaccinated people could go unmasked. But there's still a recommendation that people who are unvaccinated should continue to wear masks, particularly when they're indoors. And this has actually created a little confusion here in the last couple of weeks, because the message from our CDC, Centers for Disease Control, was very clearly that vaccinated people could unmask. But really, I think that gave a lot of freedom to people who were unvaccinated to perhaps think that they could also go unmasked. Now, the reason why is that despite our concerns about variants, so far, the vaccines largely used in the US, which have been the Moderna vaccine and the Pfizer vaccine and the Janssen vaccine, have seemed to be still effective against the variants that are mostly circulating in the US. So the variants mostly circulating in the US are the 117, otherwise known as the UK strain, and some P1, the Brazil strain, a little bit of the 617, but not as much. So our public health guidance is that so far the vaccines are so effective, and because we have such a relatively high overall rate of people who've gotten at least one dose, there was a big push to kind of let those people who were vaccinated feel like they could take some release from the restrictions they had been putting themselves under. But in practice, I think, as you said, this advice to vaccinated people maybe gave a little bit of liberty to people who were yet unvaccinated. And what I'll also say is that even though our caseload is going down very much, if you separate out our vaccinated people from our unvaccinated people, we actually still have a relatively high rate of infection among the unvaccinated and a relatively consistent death rate among unvaccinated. So what we're really going to start seeing is this kind of separation of the pandemic, and pockets of communities or people who are not vaccinated continue to get infected, whereas those who are vaccinated are to the large extent still protected with very, very, very few breakthrough infections despite the variants.
So just a follow-up question to that, and then I'll come back to Dr. Karant. What is the response, you think, to the Indian variant of Pfizer and Moderna? And you said there hasn't been much study, but if new variants like those keep coming, how certain are you that these vaccinations are going to be effective?
So I think there's kind of two approaches to studying that. One is in the laboratory, where scientists create pseudoviruses based on the variants, and then they look at neutralizing antibodies in kind of in vitro in a controlled laboratory environment. And then the second approach is to look in public health. Okay, if we're vaccinating actual people, are they actually getting infection? So far, we don't really have enough real world evidence to be 100% certain about the vaccination in the public health, but based on the laboratory studies, which are ongoing and still new and still emerging, it does seem as though antibodies are being created or able to be created to neutralize the variant, the 617 variant. So I think the initial evidence that I have seen, and I look to Dr. Karant for his opinion here too, seems that for the moment, the concern, at least for the Janssen vaccine, Pfizer, Moderna, those are the ones that I have seen some papers about, and also AstraZeneca, that there is expected to be effectiveness of the vaccines against that variant. What might happen in the future with future variants, or what might happen in the real world setting, I think we're still tentative to try to be able to understand.
Mm. So Dr. Krant,
just
what is your view?
Yeah, just to add to what Dr. Professor Ivers said, I think I did touch upon this on the previous of the question prior as well. So I think there is not much data yet to say that they are ineffective completely. They may be less effective, perhaps, or shared less effective, if I may say. Now, unpublished data from our own setting, what we have seen in the last 1.5 months or 6 weeks of the second wave, and the experience that we have had with the first wave. As you know, healthcare workers and frontline workers were vaccinated in our country as the first, as the first wave, or the first set of citizens who are vaccinated. So if you look at the intensity of the infection this time, the numbers of infection this time, we have less than 15% of the original number of people who were actually infected among healthcare workers. So if for every 100 patients that we see, I'm just talking of my hospital data, which is also reflected in unpublished report across. We see very, very few healthcare workers who have actually, one, got an infection, or number two, got severe infection. So what we need to understand is that vaccines do not give 100% protection to all, but it gives what we call a 70 to 80% or 60 to 75% protection, which is decreases that much in infections, but at the same time decreases the severity of the infection. I think at the end of the day, efficiency is not measured only in terms of decreasing infections, but it also means decreasing mortality. So I think those are the two things that we need to understand. And there is very good data, both from, we are still working on our data, and a lot of other centers are looking at that as well. We do understand that there is enough and more suggestion that vaccinated people have much lower incidence of infection or lower incidence of severe infection. And when we cut across our patients who came to us this time into the ICU, we have noted that there's only 2 patients of about more than 300 who are fully vaccinated who needed ICU, of which there was only 1 who went on a ventilator, and no deaths. This again is unpublished data, but we are still looking at it. I think that says it all, that vaccines are effective. And we know that the second wave is largely from the B617 sort of virus mutant variant. And of course, I don't have data from regional areas to say which is our strain, etc. But whatever data we have is most infections, more than 85% of infections in the second wave are coming from this new double variant and double mutant variant. And therefore, I think that answers the question that it is efficient, maybe or may not be less efficient. We need more data. And also, if you look at the epidemiology that or demographics of our patients, more younger people are getting infected as compared to the last lot where we had elderly patients with chronic kidney disease and a whole lot of other things who are targeted for vaccination in this, prior to the second wave. So it certainly means that the vaccine is effective. Whether it is less or more, I think we need more clinical or real world evidence for that.
Of course, we see on TV a lot of prominent doctors with both vaccinations having been impacted and passing away. So, but you're right that maybe the numbers are smaller versus if they had not been vaccinated. Also, in Dr. Krant, we've seen anecdotal data that people who got the Pfizer and the Moderna vaccine have antibodies, and they do the antibody testing of 400 plus. But people who've taken the Covaxin, the antibodies are only showing up between 13 to 15. How do you explain this disparity?
So 2 things. First and foremost, the antibody response, what we measure, which is actually what we call the spike protein antibody, may not necessarily always translate into clinical ground realities that the efficiency of the vaccine is down, number one. Number two, yes, if you look at the modus operandi or mechanism and how the mRNA works and how the Covaxin and the Covishield work, which is more based on the neutralizing antibody theory, you would find that there is going to be a difference. So it is likely that the antibody response for the mRNA is more, because we are actually targeting the genetic, the integral part of the virus, which is the genetic material, as compared to the spike protein, which is looking at the peripheral or the spike protein, glycoprotein itself of the virus, which is the envelope of the viral particle. So it is, there could be a difference in the efficiency, but I think just by measuring the height of the antibody response, it is a little difficult to say that in real world, it is not effective. In fact, if you look at data from Covaxin itself, initially they said 65 to 70, and today we are talking about 80 to 85% efficiency. The same thing in real world evidence is true for the AstraZeneca Covishield as well. We find that compared to the initial studies which came out in the earlier part of the year to now, which is the real world evidence we are talking about, with the data from the UK, we do find that the efficiency seems to be much more effective of the AstraZeneca vaccine as it was thought to be 2 months ago. The third thing that we need to understand is as more and more people get vaccinated, you do find that the efficiency of the vaccine starts getting better and better. So I think there are a number of factors when we talk about efficiency. So it's not only a mere number of infections, mortality, etc. But as I said, it is also how many of them have severe infection, how many less people are getting infected, how many need ICU. So all these things do matter. So I think just looking at an antibody response, which is more of sort of an in vitro or a post-vaccination kind of a data, we have to look at it in the real world, because usually the real world data may be better or worse when we talk about for most therapeutic interventions.
So you're saying that even if the antibody response to Covaxin is low, and those in India who've taken Covaxin will not be will be almost as safe as those who've taken a Moderna or a Pfizer, broadly speaking?
Yeah, I would not say as much. There could be a 10-15% difference, definitely, because we know that even from the studies, the best efficiency we talk about with both Covaxin and Covishield is around 80 to 85% with appropriate timelines taken, the appropriate gap between the two doses and the post-second dose timing, which is about 4 to 6 weeks when the full efficiency of the vaccine is seen. And we also know that from the mRNA data, we already knew that it is about 94 to 95% efficient. So definitely the efficiency, as we know today from the Moderna and the Pfizer, is a little higher, about 10% more. But I think we do have logistical implications as well. Because both Moderna and Pfizer, of course, now the things have changed. Maintaining the cold chain of minus 70 degree in a hot, humid, tropical country or a temperate country like India is also going to be difficult. So it is not only looking at the efficiency, but also, as Professor Iver said, the real world use and the real world practical application of a vaccine is also very, very important. So I think 10% or 15% this way and that way is not going to make such a big difference. I think we need to understand that and take what vaccine comes our way and which is available. Only thing what we need to ensure is that both doses of the vaccine are of the same type, but even that is now changing, as there are some early reports coming out from the Western world, which is showing that mixing of two different vaccines seem to be as efficacious in specifically with respect to Pfizer and Covishield. But I think we need more data to about mixing other kind of vaccine shots.
Right. In fact, I've heard of some people who are going from India, say overseas, and they find that the Covaxin has given them only 13 or 15. So they're going and taking a Pfizer or a Moderna overseas, thinking it'll boost this cross-vaccination or boost their antibodies. Dr. Ivers, any views on that?
Yeah, I endorse and agree with Dr. Karan. In fact, here our FDA recently recommended against checking antibodies as a measure because we had some folks who were measuring antibodies, wondering about their individual response, and it's really not recommended to be checking that. I think in addition, I would elaborate on what Dr. Krantz said by saying that there are, different components to immunity, and measuring antibodies is just one type of the immunity that we hope the vaccines induce. There are other kinds of immunity related to T cells and B cells, and those are not measured by antibodies. So I think it can become a little bit just distracting, perhaps, to be overly worried about initially the antibody as a measure of the response. We don't really know. Perhaps in the future, we'll have better understanding from research of how well the antibody level actually maps to protection. But for now, what we're seeing for all of these vaccines is that they're very effective against death and hospitalization. And so if you think about, there are kind of two needs of a vaccine. There's a public health need where you want to try to reduce the rate of the infection in your community, in your country, in the world, because the less virus that's circulating, the less anyone is likely to get it. And so you want to have overall just as much dampening of the likelihood of infection as possible in the community. And then obviously there's the individual protection. If I get vaccinated, I want to protect myself as high as possible. I'm not always just thinking about my neighbors there. So I think that's where it gets into, well, is it 85% or is it 90%? But considering how serious the infection is without a vaccine, I think, as Dr. Grant said, any vaccine that can take your own risk of being hospitalized or dying from, X level all the way down by 95 or 85% is a good vaccine to get.
Mm-hmm. So a few questions on the treatment protocols. Dr. Karant, I'm going to ask you this question. Why are some of the treatment protocols in India different than the rest of the world? For instance, in India, people are using ivermectin, which is not used globally. Also, remdesivir is being used quite a lot in India. And in fact, the treatment protocols differ between cities. So in Mumbai, I'm hearing there's much less use of remdesivir, but in Delhi, there's a lot more. And also plasma therapy, I don't hear much of that being used in some other countries as we do in India. So I'd like to hear your views on the treatment protocols in India and whether they're consistent enough and why they're different than global. And then hear Dr. Iver's view on the treatment protocols that we've been using in India.
So you asked about 4 or 5 questions. I hope I can get the order right. So the first one was about, I will start with the simple ivermectin drug. So there is good data to say that ivermectin has very good virucidal activity in vitro. Especially in very high doses, there is a good mechanism and what we call as biological plausibility of how it works. The second thing is it is a very simple, cheap, economical drug which is available and can be used very easily in settings where even in a kind of a primary health center and very interior parts of the nation, rural areas, it's very easily something that can be used. Now, there is data from both Western literature, world literature, what we call as meta-analysis studies, which have shown that ivermectin is useful, not only in treatment, but also in prophylaxis. In fact, one of our very famed critical care experts from the US itself has also done a study who has said that it is a very effective treatment. In fact, people went to the extent of even saying that if everybody in the world is given ivermectin, we can probably put an end to the pandemic. I think that is probably taking it a little too far. We don't have probably that much data to support its use. But there are small studies from the Indian subcontinent as well, which has shown that ivermectin may be efficacious. Now, we could go on debating about the pros and cons or the usefulness or the non-usefulness of these medications till the cows come home. But I think to put it very, in summary, 2 or 3 points, ivermectin is a safe drug. It is very easily procured and can be quite economical, and therefore whatever the benefit it can offer for mild disease, we can use it because there is good biological plausibility. As I said, in vitro data or data from outside human studies in the labs have shown it to be useful. So that's one about ivermectin. Secondly, coming to the question that, is the treatment protocol highly varied? I will go to remdesivir later. I think I will touch with the protocol part of it as a second question or a second answer to your question. Now, the MOHW has given guidelines. I should admit there's been no recent modification in the guidelines, but I think the initial guidelines which have come have undergone a few revisions. But of late, I think we are busy fighting firefighting the essentials of oxygen and other drugs. So therefore, probably we have not gone to revisit some of our old protocols that we went through the first wave. But each and every state has had based on a federal structure, has the empowerment to look at their own local sort of needs, requirements, availability, and use it with adequate local modification. Like in Karnataka, we do have a technical committee or the task force which goes through the national guidelines and does make local modifications. As you know, UP and one or two states in northern India were the sort of pioneers to push ivermectin. Now, ivermectin has come into some of the southern states as well. So I think every state has its own minor modification that can be used based on their technical expertise, based on the availability. And to some extent, I think we are talking about a pandemic emotion, a pandemic psyche. It is very important to address that as well many a time. So, sitting in a technical committee in an ivory tower, it's very easy for us to say that, I will not do this and I will not do that. But when the same me from the ivory tower come down and, as you said, sitting in the trenches, firing at the virus and seeing people coming and dying in front of me, I think I would do anything and everything, including probably non-modern medicine sometimes. Not that I've done it, it's just a matter of, I think, playing on the public psyche as well, which we need to respect many a time that, okay, I'm giving you something on a video consultation, which I can use. So I think that way there are certain local modifications which are being done according to the availability of the expertise and the medications. So
and what about plasma therapy?
Yeah, I'll come to remdesivir next. So remdesivir, I do agree, I think has been rampantly misused, if I may say, in India. And I think that is what is one of the reasons why we are actually struggling to actually cover or get this demand sorted now. Because right from the recovery trial to a number of guidelines have indicated that remdesivir has a role very early in the disease for moderate to moderate disease, not even for mild. So we had a very clear guideline which said that somebody ends up needing oxygen, you start remdesivir. Somebody ends up on a ventilator or not needing oxygen, remdesivir is of not of much use. Or somebody comes after 10 days, remdesivir has no role, but people just went on prescribing remdesivir as if it was the panacea for all evils of corona. And as you know, today we are struggling this scenario where there is no remdesivir available at all. The fifth one about plasma therapy, absolutely no evidence to support its use. It is only used in certain times on an individual basis, which we do use when there is a excessive demand from the family, sometimes to play to the family's emotions, but otherwise absolutely no role. There is enough and more evidence to say that it's of no clinical consequence at all.
And Dr. Ivers, how do you see the treatment protocols in India? I've spoken to doctors in the UK on ivermectin, and for instance, they say, oh, this is a medicine for lice and parasites. And how come Indian doctors are using this? So your view on the protocols that are being used in India, and how is that different than what was done in the US in the midst of the surge?
Yeah, I think that's the key thing. In March and April of 2020, when we were having our first surge, and we had, globally very little information about what worked and what didn't work from trials, we kind of gave our patients, we say here, the kitchen sink. As a doctor, you don't want to have your patient die in front of you if you think that ivermectin might work or hydroxychloroquine, and if they have relatively few side effects, we tended to kind of do an all-in approach. Since that time, our protocols have definitely evolved and changed. So here in the US, and the National Institutes of Health and the FDA and also the European Medicines Agency would say that there's no reason to recommend ivermectin. So generally speaking, we don't use ivermectin. However, we are in a more fortunate situation in that we have not had stockouts of remdesivir, say. So I think what's happened to us is that we've moved in the US, we moved from a let's try everything, and ivermectin, as you say, is typically used to manage parasitic disease. However, as Dr. Kran said, there is some laboratory suggestion that it has antiviral therapy. So there was antiviral effects. So there was certainly a premise for its use. And I think, but we have totally moved out of favor of using ivermectin. So we don't use ivermectin for our patients, but we do have remdesivir quite readily available. So our protocol would call for patients whose oxygen level dips to a certain amount to get a certain course of remdesivir, to get a certain course of steroids, but not to use ivermectin or hydroxychloroquine. But I do appreciate how, in a crisis and the context of wanting to do something, people tend to give prescriptions, but that is not what we're recommending right now. I think ivermectin and hydroxychloroquine have become, two of the most studied pharmaceuticals ever. And I know there's another multi-center trial that was just started recently to look at this, because obviously if we had an oral antiviral therapy, this could be a game changer for the world, and we could use vaccination as a public health tool and an intervention as a pharmaceutical to actually treat our patients. Because obviously a vaccine is only preventing, but we want to be able to treat the people our patients that we see, but we would very much steer away from that. For us, convalescent plasma has been the more controversial. Overall, I'd say a good majority of my colleagues would say that there's not a major benefit or indication for convalescent plasma. That would be my interpretation of the literature, especially because most of the time we find the patient too far ahead of their disease, and giving them kind of undifferentiated plasma is not necessarily that helpful. But there are still some scenarios in which we would prescribe it, especially if we had, for example, a profoundly immunosuppressed patient, or in some cases for compassionate use, what we would call compassionate use. So there's probably still a few people who are prescribing that, but overall there's less, it's less in favor than it was, say, 9 months ago when we were in the first or second surges that we had.
And Dr. Ivers, do you also prescribe to home isolated patients like we do in India, doxycycline or some of the antibiotics?
No, we also had a period where we would prescribe azithromycin or doxycycline, and we do not tend to do that now as part of our protocols.
So Dr. Karan, why do we prescribe those in India?
Yeah, so I think I've already answered that question. Yes, the evidence for it is very, very low. But I think based on, again, the biological plausibility and the fact that there is some in vitro lab data to say that it is useful and does have good virucidal activity, we still do use it. And relatively benign drug, both of them. And that's the reason, we use it. And again, the comfort of a video consult is still very, very new to the Indian public, and for that matter to the Indian treating doctor as well. So I think when you're sitting across a few kilometers away, seeing somebody on a screen, which we are still in the learning curve, I think it makes both the doctor as well as the treating person feel comfortable that we are giving them something to treat. And when something comes in a guideline, it is always difficult to ignore it and say that I will not do anything at all. So as of today, it is the guideline in many states, including the state where I come from. And therefore, I think we are sort of cajoled into giving that and ensuring that something is prescribed to the patient. Now, just to answer that question in a slightly more pragmatic sense, to be very honest, not many viral infections do actually have treatment. Most of the time, being in an ICU setting as a critical care specialist, a viral infection is largely managed to what we call a supportive care. And this applies to dengue or any other form of hemorrhagic fevers, anything that we know about. Perhaps there are very few antiviral medications which are available, and very few viral infections that we can treat, including HIV and possibly a virus called herpes simplex, very few of them. most of the other viruses are all we look at is what is called as supportive care. So I think that will probably stand good even for COVID. And I would even go to the extent of saying probably we will never find a one-on-one antiviral medication, unlike a lot of antibiotics that we have.
So I have a few more concluding questions that I will keep for the end. Our audience is quite actively asking a lot of questions on the chat, I see. So I'll turn it over to Aditya Khemka. Just to give you some context, at InCred, we believe that there will be tremendous amount of healthcare capacity that will need to be added. And this sector is going to see a lot of investment. So we've launched a healthcare fund, and Aditya Khemka leads that. So I'm going to turn it over to Aditya to ask a few of his questions and then moderate the Q&A from the audience. And then I will give I'll ask some concluding questions at the very end.
Sure, Punita, and thank you, Dr. Karanth and Professor Ivers, for your time today. So just a few questions from the audience, and some of these are obviously similar to what questions I had jotted down for myself. Firstly, the most popular question that people want to know is, when is the pandemic going to end, right? I mean, we have had so many waves, wave after wave in few countries. I believe Japan is experiencing the fourth wave now. They've already had 2 of them in India and a few in US and other countries. When do you foresee a pandemic-free world? When do you see a normalized life? So question to you, Dr. Karanth, and then I'll take Professor Ivers' view.
Right. So I think it is a little hard to predict when the pandemic will come to an end. But I think we will see through this year, we will continue to see COVID to be afflicting our lives, both in terms of our behavior and in terms of our infection. Now, if I can draw a leaf out of the previous pandemic experience of the 1918 Spanish flu, or even a couple of other pandemics or epidemics that we have seen, each of these pandemics have a life cycle of about 18 months to 24 months. So if you take a leaf out of that, probably we are looking at least a couple of years will be needed. I think a more pragmatic answer to your question, more than the timeline, would be to see how aggressively we can vaccinate ourselves and get to what is called as herd immunity. Possibly, we still don't know what is the threshold cutoff for herd immunity with COVID, but for a lot of other infections in the past, including influenza, we know that about 70% of the population, or 2/3, get immunized, either through getting an infection or through a vaccine. We do find that the virus starts, or the pandemic or the epidemic starts winding down, unless there is a mutation which may happen. So in that sense, I think we need to target that number. At least about 50 to 70% of our population needs to be vaccinated/infected and develop antibodies. And you might find that there is a good grip we would probably get on the vaccine, on the pandemic itself.
Sure. Professor Ivers, your view?
Yeah, I think, we don't know at all when the pandemic would end. Some pandemics are still going on, tuberculosis, HIV infection. We just don't really always understand exactly the dynamics and what the tipping point is in terms of how many people have to have had the infection. We don't really know if you've been infected with COVID-19, if 18 months in the future, that would protect you from a future variant. So we don't really know if this will become an annual seasonal surge of cases, or if we might actually reasonably expect that with a certain number of people infected, that the pandemic and vaccinated, the pandemic would just stop. So I like to try to be optimistic, but at the same time want to be pragmatic and say that I think we're probably going to see continued waves of these infections until we have a very good majority of people vaccinated and or infected, though we don't really know how long natural infection actually next for the future. So I think with that amount of uncertainty, I think it means you have to kind of double down on a vaccination strategy, especially considering how impactful the infection is on individuals and on kind of local communities and economies.
Fair enough. But we are sort of using vaccination and the end of transmission as substitutes here. Does a vaccinated individual not really get infected? Can he not transmit the disease even after he's vaccinated?
Vaccination is dramatically reduces the likelihood of being infected in the first place. And it seems decreases even amongst those who are infected. If you have an escape infection, seems to reduce even the viral load of the person who's infected. And so that we hypothesize should translate into reduced transmission to others. Now, actually, to go back to a comment we made earlier, it was the interpretation of this science which led our CDC to say that vaccinated people could now interact with each other without masks. There is some small amount of still infection amongst vaccinated and presumably some transmission, but it seems to be so small that it is no longer of a public health concern. So they're not totally interchangeable, vaccinated and transmission. And it will depend, I think, on different vaccines. So I think what we will see here in the future is, as we have a kind of portfolio of vaccines and the real world use of those vaccines, and studies that study the vaccinated and see what variants are occurring amongst vaccinated people. Is vaccination enriching certain variant populations? We don't really know all of that yet. So we'll know a little more in the future, I think, how different vaccines play into the actual transmission. But overall, if you think about it, there's two reasons why vaccines reduce transmission. One is just because there's less people with the infection. So you're less likely to encounter another host that's susceptible. And then also it definitely seems as though those who do escape and become infected seem to have much less virus in their body and less symptoms. And we know that symptomatic people tend to transmit more readily than people who are asymptomatic as well.
Yeah, fair enough. There's been a lot of changes in the way the treatment protocol has evolved over the past 12 months in COVID. And Professor Ivers, you were alluding to some of those changes in US, whereas Dr. Karanthi was speaking for the Indian territory, how it has been working. There are certain new drugs which are under development for COVID treatment, and I just wanted to know if you guys have a view on some of these therapies. One is molnupiravir being developed by Merck, where they have seen some very encouraging data in the initial trials in terms of the antiviral activity of the novel molecule. Another is Roche's cocktail drug, casrizumab and imedivimab, where they're again seeing some good antiviral properties of the of the drug. So, any views on these new therapies, and would these therapies sort of reduce the need for vaccination itself because they would maybe even have some prophylactic properties to it? Dr. Karanth, your view?
Yeah. So I think vaccination and therapeutics are two different arms of the same what I would say is the approach. Vaccination is prevention, which is done to ensure that somebody doesn't get infected, which is what we want to prioritize. Treatment, of course, somebody gets unwell, it depends on how sick they are, and the treatment could be for a mild disease and raging on to a very severe disease. Now, coming to the antibody mixture from Roche, it is still, there is positive data, I will say it like that, but most of the most of the patients who were looked in that were not very sick patients. And of course, it was correct that very early on, they found that people didn't progress on to severe disease, perhaps. There was, and it has to be used very early. They found that the number of days of hospitalization got less, and the antibody response was sort of much better. So I think there is good early data to support it. But I think it's too early to call it that this is the, again, panacea of all the cure that we can talk about, number one. And the same holds good for the other drug as well. I think these are still very early studies. We need more data to be very categorically saying that, yes, this will be a game changer. I think any of the therapeutic interventions that we have known till today have not been shown to be a big game changer, if I may say.
Understood. Professor, I was one for you on vaccination from the audience. Most of the people have short questions on around the need for vaccination once you have gotten infected. Do you still need vaccination if you have already been infected once? So that's one part of the question. The second part is, if you have been vaccinated, how long do you think the protection against the virus lasts?
Yeah, our current recommendations are that even if you had COVID-19, that you still should take a vaccine if you have access to a vaccine. I think, again, in the US, we now have vaccines at local pharmacies, in the grocery store. We have a surplus, really. I mean, not, we have more vaccine around than people every day even wanting one. So, it's easy enough to say, yes, even if you had COVID-19, go please vaccine. From a public health priority perspective, you could imagine that certain authorities might say, look, if you've had it, you go to the back of the line and let's vaccinate other people first. But it's still recommended. And that is partly because we don't actually know yet the answer to the second question, either for vaccination or for natural infection. We don't really know how long the immunity lasts. We are hopeful that it lasts for a long time, but some of the pharmaceutical companies are saying we will need boosters. I don't think we have enough scientific evidence for that yet, but I think the jury is still really out. We're going to have to see what happens and learn by doing, as we are, to try to understand what the duration of immunity is. I would hope it would be long lasting, but I don't think we exactly know that yet.
Fair enough. Dr. Karan, this one's for you. So, in India, what we have seen that the second wave, the younger population, as you already discussed during your opening remarks, has gotten more infected. And children also seem to be susceptible now to this virus, whereas earlier it was thought that children were probably not that susceptible. So is there really a prescribed age limit up to which the children can take vaccines? I know it's not open for vaccination in India yet for the children, but in US, for example, children have been taking vaccinations. So,
data from study, I think the Covaxin trial is on at the moment, the phase 3 trial for 2 years to 2 to 18. So that will be, I think, mid-June to late June. I think we should be having the preliminary reports of that. Pfizer, of course, still they have relaxed their age limit to 12 to 18. So see, this is all based on studies. So unless we do a study in the younger population or in the children, we are talking about teens for Pfizer, and once we get the data for Covaxin, we will know it better. So I think till we have some more data, and unless we actually have what we say the results from the phase 3 trial, it is very, very hard to say that children vaccine can be used on children or not. But whatever so far has been used, the interim analysis looks like it is quite safe. So we have to wait for the reports of these, for the results of this study to come out.
Fair enough. And Dr. Karanth, in your experience, once someone is had a COVID infection, and as Professor Ivers said that despite an infection, it is basically being advocated that one should take a vaccination. So, in your experience, how much time should a Indian patient wait post his recovery from COVID before he goes out and takes a vaccination?
Yeah, so I think whatever we know today is we are learning constantly. I think initially they said 6 to 8 weeks, and now that they've said up to 3 to 6 months we can wait before the next before you go in for a vaccine. So this is still probably an evolving field, and we will have to probably go by the recommendation which is given by the scientific community of that particular region at that particular point of time. So this may change further, and as if we come to know that the immunity is long lasting, we may even say that you are a infected or a post-infection person, go back to the back end of the queue. So I think right now we still don't know enough about it. So therefore, to keep matters simple, everybody needs to be vaccinated is what we are going by at this point of time, making sure that you have adequate gap from the time you have had the last infection. The reason for the gap is, of course, because we need to ensure that there is good immune response, which does happen, and we don't want any complication arising out of the vaccine. And most importantly, the immune response to be optimal needs to be given optimal time duration between the infection to the vaccine actual process of vaccination.
Understood. And this one is for you, Professor Ivers. So, given that Covaxin is not on the WHO list, and, we have already discussed that antibodies are not the best way to judge a vaccine's efficacy. But given that there is that perception, and, there are people in India who have already taken the first shot of Covaxin, and they are just curious whether, is it possible, or is there a protocol where when they have taken the first shot of Covaxin, can they go out and take a second shot of some other vaccine rather than Covaxin? Is there any studies which substantiate that such a treatment protocol can be done, such a vaccination can be done?
So I recently saw a study that was looking at mixing between AstraZeneca and Pfizer vaccine and seemed to have a robust response. But I think, there's no, I think the concern one might have in theory about multiple vaccinations would be that you would have some over response of your immune system and that you're triggering your immune system too much. But I think there's a lot of interest, obviously, in many global settings to see if there's a mix and match approach, if that's effective, if it's more effective, because it's targeting different components of the immune system, if it might be better to do that. But I don't think there's any recommendation that I could give at this moment about doing that. As Dr. Karanth and I keep saying, I think so much continues to evolve. So I would say I wouldn't recommend it right now, but I wouldn't be surprised to see coming weeks and months more information coming out about what happens when you mix types of vaccines, especially considering the scarce vaccines that we have. I think if I put my public health hat on, I would say add a vaccine dose, complete the series from the series that you're in, and let others who don't have any vaccine get the shot that they're in, as opposed to being concerned. If you're still concerned about your own protection, of course, you can still take in the other approaches. We know that masking is very effective. And so if you're in a situation where you can wear a mask and the people you're with can wear a mask, and you've had 1 dose or 2 doses, even of a vaccine that maybe you think is not as effective as another vaccine, you're still going to be very well protected compared to someone who has none of those things.
Correct. Fair enough. And we have been discussing the Pfizer vaccine, the Johnson & Johnson vaccine, and the Moderna vaccine, but we haven't really spoken much about the Sputnik vaccine, the Russian vaccine. So, Dr. Karanth and Professor Lewis, for both of you, any first impressions from this Russian vaccine?
I don't have much experience yet. I think it's just come to India, but whatever literature that we review shows quite a good efficiency of about 91% odd. And also, I think it is quite practical to use it because the storage is between, somewhere around -8 to -20 degrees, which is not too difficult to manage. So I think on those lines, if you look at it, it is equally good, if not better, to the Covishield and the Covaxin that we have. So just to make the question a bit broader, I think we should look at it as Professor Ivers already mentioned previously as an answer to one of the questions. I think getting yourself vaccinated is important. It doesn't matter what kind of vaccine or what variety of vaccine you are looking at. And I'm pretty sure we get more data as we move further on that, you can mix and match vaccines and you might find that there is some protection, if not a lot of protection that we will get. I think the emphasis should be on vaccinating rather than saying that should I take this or should I take that. So rightly, as Professor Ivers put it, use the vaccine. If you have already taken 2 doses, don't try to, usurp somebody else's chance. I think let somebody else get his or her shot and ensure that you educate people to take more and more of the vaccine. I think that is what the priority is got to be.
Professor Ivers, do you have a different view here?
No, I totally agree.
Okay, fair enough. Dr. Karan, this question is for you.
We seem to have lost Aditya.
I think we lost Aditya. Meanwhile, I can just jump in and ask some questions that the audience has sent. So one of the questions that they've talked about is the excessive, Dr. Karan, the excessive use of steroids and what that means for this black fungus and, that's being talked about in India. Yeah,
right. So I think we should, I do admit that I'll just take a step backwards. We know that 2 proven therapies in COVID infections is 1 is steroids and 2 is blood thinners, or what we call as anticoagulants. Yes, it is the only 2 proven therapies we know which has good data that it saves life. Now, having said that, picking up the right patient to actually have these two modalities of therapeutic interventions is very, very important. And just because there is a therapeutic modality, people have been using it and misusing it for every person, every particular person who comes positive. We have seen patients who come to us with steroid therapy, even when they are completely asymptomatic or very mild disease. So there is a specific indication where steroids are used. There is a specific duration for where the steroids are recommended, and to a certain extent, a specific dose. Without being too diplomatic, I think what we have noticed as an ICU team is that we probably use far lesser dose of steroids than what a lot of people use outside the ICU. So I think steroids need to be used in a very selected population of patients in the right stipulated dose, because overdoing it has its own set of problems. I think that's the first sort of semi answer to your question. The second part of it, what you said was, is there a relation to the fungus? Now, that is a bit of a debatable point, because people have been using steroids for a lot of things even in the past, and not many of these patients have actually come back to us with mucor. So whether the steroids itself is causing the mucor or there are other factors which are contributing to it is a bit of a debatable point at this stage. But we know that there are certain factors like high blood sugars which happen as a consequence of steroids, people who are diabetics, and the COVID itself is known to cut off a certain specific arm of the immunity called the CD4 and CD8 suppressor cells, which have a direct bearing on exacerbating or worsening fungal infections. So I think at this point, because this is a unique problem, or a fairly unique problem which is localized to the subcontinent and more specifically to India. Not many other countries have seen so much bulk or rise of increase of mucor or what we call as black fungus in a setting of COVID or post-COVID. So I think we still really have to look very hard at our data. Is it our practices, or is it the therapeutics, or is it just the disease? And the genetic makeup of our population which is contributing this is what we are still unsure about. But yes, having diabetes, high sugars which are attributable to steroids are two definite factors, and to some extent the COVID infection itself may be playing a role. And I think it is very important to ensure that the dose of steroids that we use is going to be very, very judicious.
Okay, there's so many questions. I know we only have about 10 or 15 minutes more. So Aditya,
yeah. So Punita, I think I aggregated the questions. So I just have two more questions, and then maybe I'll pass it on to you.
Okay.
The one question I have here from the audience is about once normalcy comes back, once people step out of their homes again, right? How do you see the immunity of the people? So COVID is supposed to immunocompromise the patients and the people around us also, because we are sitting back at home, we are not going out of our homes. So do you see that once people start a normal life again, whenever that might be, there will be a higher incidence of some of these infections and bacterial infections, etc., because the immunity levels in people would have just dropped a lot because they have not been venturing out of their homes? Dr. Karanth, you first.
Yeah, I would like to reframe that question a bit differently. I think infections are higher in the post-COVID scenario. I don't think stepping out of house will sort of reduce your immunity, maybe not. Yes, I mean, we could always argue that, the psychological effects of being at home and the stressors of being at home may predispose to certain things, which is a general sort of immune boosting thing, or a general health concern, I would say. But I think in somebody who has recovered from COVID, we are seeing more and more infections of various types, and the most recent one being post-COVID, the black fungus or the mucor infections. So we would not completely rule out that people who have recovered from COVID, we don't know. It's a new virus in town, and the after effects of that, I think we will know in the next couple of years what are the newer problems that we see, and that is what we call as the post-COVID effect, which we have seen already beginning to happen in our ICUs and outside as well. I think right now the raging fire is the COVID itself. So I think it's very important to understand that once we are releasing ourselves out of home, we are still not fully a vaccinated population. I think full vaccination is seen only in 4%, which is abysmally low for the kind of population that we have. So I think that is the first precaution we need to be aware of, because It is public memory is short, as we know, and we cannot commit the same mistakes that we committed before the second wave. I think more than what will happen post-COVID, I would like to emphasize that we are not yet post-COVID as a society. We are saying that there could be a third wave, that could be a fourth, and many more. So we need to understand that we have to first ensure that our behavior remains the way it is now. And I think that is much more important. But yes, post-COVID, when somebody recovers from COVID infection, they are likely to be susceptible to a whole lot of infections, which we probably need to learn more about as we go further on.
Right. And Professor Ivers, your view on what's been happening in US. So obviously the COVID wave has somewhat flattened out in US now. So have the post-COVID recovered patients seen a bout of more infections, or is it that the general population at large is not seeing any higher incidence of other infections?
So a couple of points. We have only rarely seen mucormycosis in our patients, and that has been amongst profoundly immunosuppressed patients. So I think, it is of urgent scientific interest to understand much better what is exactly happening and what the epidemiology of mucormycosis is in India amongst the patients. I've done some consultations with colleagues in various facilities there, and most of those patients have had either very high blood sugars, very protracted steroid courses. We have been using very shortened courses of steroids, but also other immune inhibitors and other immune suppressant medications as part of kind of the care of patients. So I think it's very important to try to understand better what's happening there, because obviously mucor is a really difficult infection to treat. It's very pernicious and can be really life-threatening. So that's one thing. We have not had the experience that we have considered that to be a post-COVID infection. In fact, in the rare cases where we have had that, we have considered that to be a co-infection related to the profound immunosuppression that the patient was on. Otherwise, infection is not a major concern amongst people in our community who have suffered from COVID and have recovered. However, we are seeing quite high rates of what is being called post-COVID syndrome. And these are chronic fatigue, these are muscle concerns, these are brain fog, headaches, other neurological findings. So we have a number of initiatives in our hospital, in other partner hospitals around the US, looking at trying to understand better this syndrome of people who have been infected with COVID and seem to have recovered, but still quite haven't gotten back to their usual self. So I think when you think about COVID in the community, we think about hospitalizations and death because that has human impact and impacts our health system, but also even people who recover from moderate illness, many of them are having very protracted symptoms, and that is an exceptional impact on the health system, and we don't totally understand those syndromes yet. But I will say infections is not a major component of that. So we're not really seeing that people are susceptible to other types of infections. And just if I may, on your point about people staying home and immunity, what we saw in the US was almost no influenza this year. Very, 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 very low rates of influenza, probably because of all of the measures that were in place around COVID-19. Now, it's been great because normally we have very ill patients in our intensive care from influenza. So the question it will be that, is it possible a year from now or 2 years from now that we will have a big impactful influenza wave because nobody had influenza this year? But that's a minor, that's of interest, but it's really a minor public health concern at this time. It's not something I wouldn't worry about immunity when I advise people to stay at home if they can. I don't think that's going to be a major concern.
Just to add on, also we need to understand that mucor itself is more of a problem in this part of the world. Even otherwise, I think we see a much higher incidence of mucor in our diabetics and such other people. Of course, being the fact that we probably have the highest number of diabetics in the world, that could also be contributing. But definitely we know that being a diabetic and high blood sugars are two very important factors that lead to mucor. And that's why this question of whether steroids directly cause mucor or directly responsible for mucor is a very debatable thing. But in our treatment modalities, we do see that we struggle to get the sugars down when people are on these doses of steroid. And very protracted courses of steroids, as Professor Ivers mentioned, are given by some of our clinicians, and I think those are all resulting in some of these problems. Yet another theory which is being sort of discussed around is that the way we have looked at our oxygen delivery, whether it's coming from the oxygen tubings, we have diverted industrial oxygen to medical oxygen. So is that causing? So these are all hypothetical questions which are still being looked at. But I think we still don't have clear answers. And I think this is something which we have to look at as a priority.
So I might, so as an infectious diseases specialist, we might have to have a little debate with my esteemed colleague in a different scenario about the role of steroids in mucormycosis, because I think we are saying the same thing.
Yeah.
Certainly, so, mucor is an environmental fungi. So definitely there are geographic differences in even what one's exposure to that fungus would be in the first place. So I certainly can see that point. I think what we see is that there are numerous underlying reasons that might put a patient at risk of a mucor infection, and they include diabetes with uncontrolled sugar, they include steroid use and prolonged steroid use, and they include other immunosuppressing medications. So certainly if you compound those things and you add those things up, you're going to have a patient that is much more at risk. But I agree that there are many factors that need to be untangled to understand better what exactly is contributing to this major kind of epidemic within an epidemic in some ways, or with COVID.
I'm not denying that steroids is responsible for that, but if you just look at purely the studies which have, a lot of other patients are on steroids, but they don't end up with these kind of mucor. So it could be not only the steroid, but there's something beyond it. And what we think could be the hyperglycemic effect of steroids perhaps causing it. But yes, if you look at it from an immunological perspective, steroids do have an effect on the, that arm of the immunity as well.
Understood. Thanks a lot for that view. Just one final question from the audience for me, and that was for me. So they say that, if a COVID is going to be short-lived, maybe a year or two, then the pharma companies which have created all this capacity to create this COVID-related therapies, what happens to that capacity? What happens to those, plants that have been created to produce these drugs? The response to that is simply that, many pharma companies for these plants are fungible in the way they are designed. So if you want to stop producing and you want to start producing something else, the plants some other drug. So closing remarks and anything you may want to add.
Well, thank you. I think thank you to both Dr. Ivers and Dr.
Punita?
Karan. Yes.
Yeah.
Can you hear me now?
Sure.
Okay. So before I thank you, actually, I have one concluding question for each one of you. So Dr. Ivers, you've talked about a global unified response, the need for a global unified response. What should that be?
We've talked a lot about vaccines, and the United States and Europe and Canada have hoarded vaccines from the world, have kind of hedged their bets on COVAX and have contributed dollars to COVAX, but then separately behind the scenes negotiated with pharmaceutical companies to make sure that we have this massive surplus of vaccine. And I mentioned today now you can go to any pharmacy almost and get a vaccine. This is, nice for Americans, but it doesn't really seem like a good idea for the world when you think about a pandemic and variants and just a global humanity. So I think that global leaders really need to come together and say, how can we ensure that and by the way, we can see how the surge in India impacted vaccine production for the rest of the world. And Africa, CDC, needing COVAX doses that were going to come from India. So we're all so interconnected. The idea that one country or one subcontinent could isolate itself and try to just work alone is really not the way forward. So I would love to see much more global collaboration on trying to address the problem as everybody's problem. Like, we're all in this together. And that was some of the narrative that we heard from global leaders this time last year. And so I think it was very disappointing to see that many of them only really meant that as at the podium in words, and they didn't really follow through on it. So I think we have to be able to come together to share the technology around the vaccines, to collaborate on the manufacturing capacity, to make sure that we can produce the billions of doses that we need, and that when one plant is down, the other can scale up. I think that's going to be really important.
Thank you. And Dr. Karant, my concluding question to you, you've obviously been in the trenches, you've been playing a very important role in the critical care units and saving many, many lives, and all the doctors in India are really putting their lives at risk to save everybody. So I was reading somewhere that the herd immunity in India is only going to be reached in mid-2023, later than, say, most other countries. Some countries like US is supposed to reach end of this year or 22 mid, and most developed countries by mid-22 at the latest. How do we and the healthcare professionals prepare for the next wave and the future variants in India, and how do we build the healthcare capacity that is needed? Any words of wisdom?
So I think we have to learn from the mistakes that we did prior to the second wave. So this has to be a twofold strategy. One is, as Professor Ivers has already told, vaccine the population. That is the only way, by only sure shot way of actually speeding up the herd immunity. Now, that is one arm of it. But I think the second important thing is that we have now learned that there has been a second wave. We cannot be complacent. We have to get ready for the third wave. And there's already prediction that the third wave is going to be hitting an even younger population. So I think ramping up beds, ramping up availability of drugs, oxygen, production and distribution of each of these things, I think, has to be a priority. Now, I think what we need to look at from a more specific perspective would be that we have to make sure that we have the capacity to ramp up in a very short time. Say, for example, you have a major institution or a hospital, ensure that you can keep oxygenated beds around that hospital rather than, isolate it from different parts of the city. Ensure that there are supply chains maintained for all these important drugs. And there are only very few things which are going to be required. It could be things like remdesivir, which again, it's there or not there, may not make much of a difference. But make sure you have oxygen, you have enough oxygen delivery devices, which include ventilator, non-invasive, high-flow nasal cannula, all these kind of devices, and make sure that there is appropriate education to people as well. I think these are some of the things which we need to ensure, and being so savvy digitally, I think, or being one of the software hubs of the world, I think that is something we have, I should admit, failed to use in both our pandemics. There's a lot of talk about going digital, going this, going that. I think that is something we can really use, because we do find that, especially in the initial phase of the wave, people just get admitted because I'm COVID positive, I just get admitted in the hospital, and they block the beds for people who really deserve it. So having a graded, or what we call as a step ladder approach to the to addressing this problem of who gets admitted and who are the people who really deserve hospital beds, and the high-end ICU beds need to be really put into perspective. I think we have to understand that we have to build our capacity to at least reach 400,000 cases a day, because that is what we saw on this wave. Now, if it is less than that, good for all of us. But if it is more than that, I think at least we have to be ready for this number, because this is a number we have seen this time. It could be worse or it could be better, we don't know. But I think not to drop the guard. I think we need to understand that the whole of this year, we are going to battle COVID, whether we like it or not. I think starting from the top leadership, political leadership, down to the grassroots people in the villages and the deep rural areas, we have to be very, very, aware of this fact. As you know, the tribal belts in the country have now been hit. I'm sure we will not even know the number of deaths which are happening in the remote parts of the jungles where most of our tribal people live. You'll just find that people just die and lose their lives. So I think whatever we can do to save every possible life is important. And whether we like it or not, certain measures like lockdown might become a necessity, as we saw from our experience in the first wave and the second wave. Only after lockdowns got imposed in various parts of the country in this wave, we could get a hang of the positivity rate and the spread of the transmission of the infection. And there are a couple of good papers which have shown that the mortality also comes down by about 40% when you actually employ these epidemiological measures. I know it's a battle between life and livelihood, but as you know, this wave has cost more lives and livelihoods than we thought about in the first wave. So I think it is a balance between the two that we need to ensure, because if we are alive, we can talk about livelihood. If you're not alive, I think the question of livelihood just doesn't come around. So I think it is to be a unified vision that we need to have. And I think we have our own experience to fall back on. Unfortunately, we failed to learn from the experiences of the rest of the world, which I should say was a very foolish thing from ourselves. I think a wise man learns from others' experiences. I think we didn't learn from others, but at least I'm hoping we are wise enough to learn from our own experience. And what we need to understand is, I think, being at the forefront, we do see the helplessness of ourselves and the people, because we were so desperate to even get beds for people. And it was really a pathetic scene to see, to have the kind of state we were in. And I think being there in the front end, it was really very painful to see that we were not able to help a whole lot of our population.
No, I think you, Dr. Kranti, very nicely explained why, you're also often giving medications, because when all things look like so desperate, then you try every hope and every treatment to, survive or, make the patient survive. So that's a very important point, and I think that I've taken away as well. And I think I can't thank you, both Dr. Ivers and Dr. Karant, enough for shedding so much wisdom and sharing so much knowledge and giving us all this advice today, despite all your busy schedules. And I hope, Dr. Karant, you get some rest before you go back into the trenches. And Dr. Ivers, keep focusing on the global health policy issues, so you can continue to advocate solutions for the whole world right now that we desperately need. Thank you very much.
Thank you.
Thank you.
I think if there are no more questions or nothing else anyone wants to add or say, we can conclude, unless Dr. Ivers or Dr. Karant, you want to add any final concluding remarks.
Just thank you very much for inviting me to the conversation, and it was great to meet with you, Dr. Karant, and best wishes.
Pleasure is mine. Same here too. Thank you very much for the opportunity, and it was always a pleasure, Professor Ivers.
Okay.
Thank you everyone for attending the call, and that concludes the call. Thank you.